Salam sejahtera and good day to all participants of Basic Life Support course. I am Dr. Victor Lim, Emergency Physician of Hospital Seberang Jaya. In this Basic Life Support course, you will learn about Basic Life Support algorithm in adult, Basic Life Support algorithm in pediatrics, foreign body airway obstruction in adult, foreign body airway obstruction in pediatrics. Next, we look at the aim or the objective of the BLS. The objective of the BLS can best be summarized as A, B, C, and D. A stands for airway. In the BLS, we shall learn how to open an airway and maintain its patency. B stands for breathing. How we assess breathing and also how to support the breathing. C, circulation. How to assess circulation in BLS. Followed by D, defibrillation. We shall learn how to defibrillate using automated external defibrillator or AED. We look at the three main organs in our body. Heart. The heart is located in the center of chest, behind the sternum. Its main function is to supply blood to all vital organs in the body. The coronary arteries are the special arteries that supply the blood to the heart muscle. That's why the main aim of doing CPR is to generate enough pressure in the aorta for the blood flow inside the coronary arteries so that it can supply the heart muscle in the hope that with adequate blood supply to the myocardium or the heart muscle, the heart can start pumping again. That's why at all times, don't ever interrupt the CPR unless really necessary. Next, lungs. The lungs consist of tiny sacs or alveoli surrounded by small blood vessels. In order to maintain life, our body must receive constant oxygen supply. Atmospheric air contains 21% of oxygen, while the exhaled air contains 16% of oxygen. Brain. The brain cells are the most susceptible to the deprivation of oxygen. Brain cells started to die after 4 minutes without oxygen, and permanent damage can occur after 10 minutes without oxygen. The common causes of sudden cardiac arrest includes ACS or acute coronary syndrome, or road traffic accident, lemas or drowning, snake bite, electrical shock, or intoxication. One of the most common causes of cardiac arrest or stroke is due to acute coronary syndrome or serangan jantung. ACS is frequently caused by unhealthy habits such as sedentary lifestyle or risk factors such as hypertension, diabetes, or dyslipidemia or high cholesterol. Or smoking also contributes to ACS. The symptoms of ACS includes severe type of chest pain, persistent vomiting, unconscious, and lightheadedness. The pathophysiology of ACS or acute coronary syndrome is due to a plaque built in the coronary artery that causing narrowing of the vessel that limits the blood flow and oxygen to the heart. Without the blood flow and oxygen to the heart, it starts to develop ischemia and die off. In ECG, an ACS or MI, myocardial infarction, will be shown in ECG as ST elevation. Or some of the time, patient might have already collapsed or develop cardiac arrest on arrival. So the cardiac monitor will be presented as VF or ventricular fibrillation or sometimes asystole. Next, we look at chain of survival. Chain of survival, also known as a sequence of events that need to be carried out in order to increase the chance or rate of survival in a cardiac arrest patient. It starts off by number one, recognition and activation of EMS, Emergency Medical Service. Number two is to provide immediate high quality CPR, followed by number three, rapid defibrillation. Number four, basic and advanced emergency medical service by healthcare personnel. And number five, advanced life-saving care and post-cardiac arrest care. So in the old days, the public are thought of number one and number two. But nowadays, because of the popularity of the BLS and the AED are readily available in most places in the public, so we expect the public to do number one, number two, and number three, rapid defibrillation as well. Okay, let me introduce you the algorithm of basic life support in an adult. If we encounter a cardiac arrest or suspected cardiac arrest patient, approach the patient, check for his response. Sir, are you okay? If the patient is unresponsive and not breathing normally, immediately call emergency services or 999. Start giving 30 chest compressions to the patient, followed by 2 rescue breaths. Continue the CPR in 30 compression to 2 rescue breath ratio. Continue the CPR until the AED arrives. When the AED arrives, switch the AED on, attach the pads on the patient, and follow the AED instructions. Next, we look at the adult BLS algorithm for healthcare providers. The algorithm can be best summarized as DRS, A, B, C, and D. D stands for danger. Always wear your full PPE, especially in current COVID scenario. One always assumes that the patient is COVID positive until proven otherwise. Thus, wearing full PPE before we approach or even start the CPR is important. Make sure yourself, the victim, and any bystanders are safe before you proceed further in the algorithm. R. Responsiveness. One can easily assess the responsiveness of the victim by tapping his or her shoulders. Sir, are you okay? Shout for help. If the patient is unresponsive, call for help. Ask for calling the emergency response system or 999 and ask them to get a defibrillator or emergency trolley if you are in hospital setting. A. Airway. Open up the airway by performing head tilt chin lift, or in a trauma case, do a jaw thrust. B. Breathing. Assess the breathing by doing inspection. If the patient is not breathing or abnormal breathing, immediately start chest compression. C. Circulation. Start high quality chest compression by push hard and push fast. Your hands should be in the center of the chest or lower part of the sternum and push deep until at least 5 cm depth at a rate of 100 to 120 per minute and allow the chest to fully recoil after each compression. The ratio of compressions to ventilation is 30:2. Each breath given over 1 second to ensure visible chest rise. Minimize interruptions in chest compressions. D. Defibrillation. Attach AED or manual defibrillator as soon as it is available, without interrupting the compression. If you are using AED, follow the AED prompt or command. If you are using manual defibrillator, you have to manually interpret the ECGs or interpret the rhythm shown in the cardiac monitor, and if it is a VF or VT, immediately give a single shot or single defibrillation dose followed by CPR for 2 minutes. If it's a non-shockable rhythm, resume your CPR immediately for 2 minutes and check the rhythm after every 2 minutes. Next, we look in details of each element of the BLS algorithm. D. Danger. At all times, make sure the environment or the surrounding is safe before you provide BLS or basic life support to the cardiac arrest victim. In a road traffic accident scenario, make sure you and the victim are safe before you approach the victim. In a drowning scenario, make sure the victim is already carried out from the water. And if it is a if it is a electrical shock or electrocution scenario, make sure the victims is already removed to a safe place and the main current is switched off before you approach the victim. And of course, not forgetting, in current COVID scenario, always wear full PPE or at least wear your PPE such as face mask and also face shield before you approach the victim. Next, R. Respond. One should always assess the patient response by doing tapping the patient's shoulder and simultaneously call out the patient loudly. Sir, sir, are you okay? Or Miss, miss, are you okay? If the patient is not responsive, ask the passerby to call 999 and immediately get you a AED or automated external defibrillator. If there is no other passerby, you are alone with the victim, stay calm, call 999 yourself, identify the location that you are in, wait for the call dispatcher to ask you question and answer the question clearly and calmly. Follow all the instructions given by the call dispatchers. Do not hang up the call until the call dispatcher hang up. A. Airway. There are two ways of opening an airway. Number one is by doing head tilt and chin lift. In head tilt and chin lift, the one hand of the responder shall place on the patient's forehead, while the others, 2 or 3 fingers of the other hand shall place on the bony part of the jaw or chin. Gently tilt the patient's forehead backward and lift the chin upward. Avoid applying pressures on the soft part between the jawbone, and avoid closing the patient's mouth completely. Another method in opening airway is by performing jaw thrust. Jaw thrust is frequently performed in a trauma patient when cervical injury is suspected. In this method, the airway is open without head extension. How to do it? The responder shall place both of his or her palms on the patient's cheek, both palm on the patient's cheek, and use his fingers, frequently the index fingers, slide behind the patient's angle of mandibles and push up. Okay, I repeat, both the responder palms are placed on the patient's cheek and the fingers are placed behind the patient's angle of mandible and push up and to open up the airway. Next, breathing and circulation. We assess the patient breathing by looking at the patient closely for around 10 seconds. If the patient has no spontaneous breathing or the patient having abnormal breathing like gasping, immediately start to give chest compressions to the patient. How do we perform chest compression? Number one, one hand, the heel of the palm of one hand is placed on the center of the patient's chest or lower half of the sternum. The other hand shall place on top of the hand and interlock in nature, like you've seen in the diagram. Then the responder's elbow should be locked and the whole arm should be in a straight manner and apply downward strong compression. The compression should be at a rate of 100 to 120 compression per minute, and the depth of compression should be between 5 to 6 cm. Allow full chest to recoil after each compression. Minimize interruptions during ventilation and also defibrillation. The compression and ventilation should always be done in a 30 to 2 ratio. 30 chest compression should immediately followed by 2 ventilations. Repeat up to 5 cycles of 30 compressions to 2 ventilation, which takes about 2 minutes. If there are 2 rescuers present at the moment, one rescuer shall perform chest compression while the other takes over the ventilation. The chest compression are done 30 times, followed immediately by 2 ventilations. Repeat the 30 compressions to 2 ventilation up to 5 cycles or around 2 minutes. Next, we look at ventilation or rescue breath. How to perform an effective ventilation? The rescuer mouth should cover the victim mouth fully. Number one. Number two, use your fingers, index finger and thumb to pinch on the patient's nose. Number three, perform head tilt chin lift to the patients to open up the airway, and at the same time give a blow air directly into the patient's mouth to ensure visible chest rise for at least 1 second. Alternatively, ventilations can also be provided via mouth-to-mask ventilation. Avoid hyperventilation at all times. Remember to follow the ratio of 30 chest compression followed by 2 ventilations. When you are providing mask-to-mouth ventilation, one must always use a EC clamp technique. 3 fingers of the responder of one hand lift up the jaw of the patient, forming the letter E, while the thumb and the index fingers hold on to the mask and press downward to ensure adequate tight seal, making a letter of C, like what is shown in the diagram. Mouth-to-mouth ventilation technique. To perform it, number 1, pinch the victim's nose. Then, number 2, open your mouth, take a normal breath, and place your lips over the over the victim's lips. Make sure your lips are fully covered the patient's lips. Number 3, perform head to chin lift to open up the patient's airway. Number 4, deliver each rescue breath over 1 second and ensure adequate chest rise of the victim. Avoid providing the air or blow out the air too fast or too hard. This is to avoid stomach distension. If one don't want to blow air to the patient's mouth, one can blow air to the patient's nose alternatively. Pulse check. Pulse check ideally should only be done by trained healthcare providers. Reason being, the layperson or normal public, they spend too much time in locating the carotid pulse. So for the layperson, they are not encouraged to locate the carotid pulse. If they see that the patient has no spontaneous breathing or abnormal breathing such as agonal breathing, they should start or continue CPR. For healthcare providers, to locate the carotid pulse, use 2 or 3 fingers, locate the Adam's apple, then slide the fingers into the groove between Adam's apple and the muscle, such as shown in the pictures. Next, when to check for carotid pulse? When there is sign of life such as presence of spontaneous movement, patients start coughing, or presence of spontaneous breathing. Number 2, when there is change of heart rhythm in cardiac monitor. Check pulse for maximum 10 seconds. If one cannot feel any presence of carotid pulse, one should assume that there is no sign of life for the victim and to resume CPR. If pulse is present, provide 10 to 12 rescue breaths per minute if there is no breathing. Recheck pulse every 2 minutes. After you have settled with the airway, breathing and circulation, now it's time for defibrillations. In BLS, the responders are taught to use the AED or automated external defibrillator. Attach the AED to the victim as soon as it is available. One AED shock should follow immediately by high-quality chest compressions. The rhythms is only checked after 5 cycles of CPR or 2 minutes. How to use an AED? Simple. Just follow the instruction of the AED. Number 1, power on the AED. Number 2, attach the pads. One patch attached at the right-sided chest just below the clavicle. The other pads attached on the left-sided chest over the apex region. And allow the AED to analyze the rhythm. And if the AED advises for shock, press the shock button. The instruction of to use the AED is sometimes is illustrated in the AED like what is shown in the picture. 1, on the AED. 2, allow the AED to analyze the rhythm. And number 3, if shock advice, press the shock button. A little more details about using AED. For victim with hairy chest, dry with a towel, Dry the victim's chest with a towel and do not use alcohol, as alcohol is highly inflammable and it could cause burn injury to the victim. For a victim with a hairy chest, the responder might need to shave the victim's chest hair to ensure there is a proper attachment of the AED pads to the victim's chest. The right-sided electrode pad should be placed to the right side to be placed on the right-sided chest of the victim. It should be placed just below the collarbone and above the right nipple. The left electrode pad should be placed on the outside of the left nipple, and on the upper edge of the pads should be several inches below the left armpit, such as illustrated in the picture. Before you shock the patient, ensure that no patient contact and warn everyone or every responder by saying everybody's clear. Perform a visual inspection to ensure that all responders are hands-off of the victims during rhythm analysis and before shock. After you ensure that everyone's a hands-off, then only you press the shock button. Once an AED arrives, switch on the AED, attach the AED pads on the victim's chest, allow the AED machines to analyze the rhythm. If it is a shockable rhythm, give one shock and resume CPR for 5 cycles. If it is a non-shockable rhythm, resume CPR for 5 cycles and check rhythm. Continue till the ALS or Advanced Life Support Provider take over or victims start to moving. Recovery position. One should place the victim on a recovery position if the patient achieves return of spontaneous circulation after your CPR effort. Recovery position can be placed either on left lateral or right lateral, it doesn't matter. So if you decided to place the victim on right lateral position, number one, you can extend the patient's right arm. Number two, the patient's left arm should be across his body and the hand is placed underneath the patient's face, such as shown in the diagram. Number three, you want to flex the patient's left-sided knee and simultaneously rotate the patient over to the right side and place the patient on right lateral position. So the final position will looks like in the diagram. One arm is placed underneath the patient's head. So it allows the patient's head to be slightly extended. This is why it is need to place in the recovery position, because it will prevent the patient from aspirating or choking on his own saliva. And number two is to prevent the tongue from falling behind if the patient is placing in a supine position. So by placing the patients in a recovery positions, one could maintain a patent airway for the victim. Hazards of CPR. Undeniably, CPR could cause some degree of harm to a victim. However, a responder should not discourage from performing CPR to a victim, because more importantly is to save a victim's life. Okay. The hazard of CPR could be rib fractures, the xiphoid or xiphoid bone fractures, injuries to the liver, lungs, and spleen due to incorrect hand position. Internal organ injury due to deep compression, or gastric distension is due to large breath volume or overventilation. For victims who vomit, turn the victim to the side, sweep up the mouth with a cloth, reposition the victim, and continue CPR. Other issues pertaining to the CPR. For victims who wear dentures, one should only remove the dentures if they are loosely fitted to the victim's mouth. This is to prevent the dentures from falling backward and obstruct the patient's airway during the CPR. What are the common errors in performing a CPR? Number one, incorrect hand position. We know that the hand position of the responder should always be placed in the lower half of the sternum during chest compression. If the hand position is incorrectly placed, number one, the CPR is ineffective, and number two, it could cause abdominal organ injuries such as the liver or spleen injuries. And another common error is failure of the responders to allow the chest to fully recoil during chest compression. Thus, there is poor refilling of blood into the heart and poor outcome of the CPR. Another common error during CPR is the responder allows their hands to bounce during each compression, and thus their hands easily slide and resulting in incorrect hand position. Number four, the CPR or the chest compression given by the responders is too shallow and too slow, and thus there is inadequate blood flow to the coronary arteries and poor outcome of the CPR. And number five, too many interruptions or too many hand-off movement during the CPR. As we know that a continuous and sustained chest compression is needed to allow the aortic pressures to build up and to allow the blood flow to the coronary arteries that can supply the myocardium or the heart tissues. When there is too many hands-off moments during the chest compression, there is no sustained pressures built up in the aorta, and thus there is no blood flow in the coronary arteries, and there is no blood supply to the myocardium, and as a result, there is poor outcome of the victim. And finally, we look at the transmission of contagious diseases. I know many healthcare providers or BLS providers are worried about the transmissions of infectious disease from the victim to the healthcare providers. One can use the barrier device during mouth-to-mouth ventilation to prevent the transmission, or in current COVID scenario, if the BLS provider is worried about transmission of COVID virus, the healthcare workers should only perform hands-on or cardiac compression to the victim. Next, we look at the basic life support in an adult choking scenario. Next, we look at the algorithm for an adult foreign body airway obstruction or adult choking scenario. Firstly, you assess the severity. Determine is it severe airway obstruction evidenced by ineffective cough or very weak cough. The victim is in severe respiratory distress. The victim can hardly speak. If it is this scenario, check the patient. If the patient is unconscious, immediately start CPR for the patient. If the patient is still conscious, immediately provide 5 back blows followed by 5 abdominal thrusts. Let's say the patient is in a mild airway obstruction scenario, evidenced by effective cough, mild respiratory distress, and the patient can still speak in short sentence or in phrases. Then you stand by the patient's side, encourage the patients to cough, and continue to check for any sign of deteriorations to ineffective cough or the coughing of the patient successfully relieve the obstruction. We know an adult is choking when he or she displays the universal sign of choking. It is shown in the diagram whereby the victim usually uses both of his or her hands to hold on to the neck. When we have determined that the choking adult is in a severe airway obstruction scenario and the adult is still conscious, we proceed to give him 5 back blows followed by 5 abdominal thrusts. If 5 back blows fail to relieve the obstruction, we proceed to give 5 abdominal thrusts. To perform abdominal thrusts, one should stand behind the victim. Wrap your arm under the victim's waist. Press your fist into the victim's abdomen. The location should be between the umbilicus to the cervicsternum. We give a quick inward and upward thrust to the victim. If the obstruction is still not relieved after 5 abdominal thrusts, continue alternating your 5 back blows with 5 abdominal thrusts until the foreign bodies is relieved. Alternatively, one can use chest thrust for an obese or a pregnant victim. To perform chest thrust, one should stand behind the victim and place your arms underneath the patient's armpit and encircle his or her chest. Then, you place both fists onto the patient's to the center of the patient's chest. Provide a quick backward thrust. In a scenario when the victim becomes unconscious, immediately support the victim to the ground. Call for help. Start performing CPR to the victim. During CPR, each time the airway is open, check for foreign body that could have been partly expelled out. Use finger sweep only when you can see the solid material obstructing the airway. Never perform blind sweep. Pediatric CPR. Next, we look at the basic life support algorithm for a pediatric cardiac arrest scenario. Next, we look at the basic life support algorithm for pediatric cardiac arrest. Let's look at the algorithm on the right-hand side of the slide. If the patient or a pediatric is suspected to have cardiac arrest, first, danger. Ensure that the surrounding is safe to approach the victim. Number 2, R. Respond. Check the patient's response. Hello, hello, are you okay? If there is no response, S. Call for help. Call 999 or emergency medical service. A. Airway. Open up the child airway by performing head tilt chin lift, and if it is a trauma situation or trauma scenario, open up the airway by doing jaw thrust. B. Breathing. Observe the patient's breathing. If there is no breathing or abnormal breathing such as gasping, immediately provide 5 rescue breaths to the child. After 5 rescue breaths, if there is no sign of life, such as the child is not moving, no spontaneous breathing, immediately provide 15 chest compressions, followed by 2 rescue breaths. The chest compression to the rescue breath ratio is 15:2. Repeat this for a duration of 2 minutes. So the principle of pediatric CPR is number 1, the victim must be 1 year old to the onset of puberty, typically around age of 12 years old. The chest compression ratio to ventilation is 15 compression to 2 ventilation. When you have more than 2 rescuer available, rotate the compressor every 2 minutes. Okay, so we are going to look into details of the algorithm again. For a pediatric cardiac arrest case, for response, if the child does not respond to your call, shout for help. Turn the child gently on his back. Open the child's airway by tilting the head and lifting the chin. Place your hand on his forehead and gently tilt his head backwards. At the same time, with your fingertips under the point of the child's chin, lift up the chin. Do not push on the soft tissues under the chin, as this may obstruct the airway. This is especially important in infants. If you still have difficulty in opening the airway through head tilt chin lift, try jaw thrust. In jaw thrust, place the first 2 fingers of each hand behind each side of the child's mandible and push the jaw forward. Airway. Open up a child's airway by performing head tilt chin lift. Head tilt chin lift can be performed by placing one hand over the child's forehead with another fingers from another hand. Gently lift up the child's chin, such as illustrated by the diagram on the right side. After opening up the child's airway, do a visual check for foreign body and remove any visible foreign body. Breathing. Look for rhythmic chest movement and abdominal movement. Besides looking for chest movement, one can listen at the child's nose and mouth for breath sounds and feel for air movement on your cheek. If the child is breathing normally, place the child in recovery position. If the child is not breathing, give 5 rescue breaths, each time over 1 second, with a visible chest rise. When giving rescue breath, in infant, one can use a mouth-to-mouth and nose technique, meaning the rescuer mouth fully covered the infant nose and mouth. In a child, use a mouth-to-mouth technique, whereby the rescuer uses one of his hands or the fingers to pinch the child's nose and cover his mouth with the child's mouth and blow air into the child's mouth. In any case, if the chest of the child does not rise during exhalation, reposition the child's head. Circulation. In a pediatric basic life support for cardiac arrest scenario, checking pulses in a child is not compulsory. One can substitute the checking of pulse by looking for signs of life such as movement, coughing, or normal breathing. Alternatively, if one decides to check for pulses, look for brachial or femoral pulse in an infant or carotid pulse in a child over 1 year old. If pulse is present or the child showing any sign of life, only continue to give rescue breath. Give 12 to 20 rescue breaths per minute. However, if the patient is unresponsive, has abnormal breathing, and displays no sign of life, immediately start your chest compression. Next, we look at the chest compression technique for a child. The location of compression is similar to adult. It is at the center of the chest or lower half of the sternum. The responder, the BLS responder, can place the heel of his hand over the chest by using one hand or two hands method. And the arm of the responder should always in a straight manner with the elbow locked and the shoulder above the patient, the shoulder above his hands. The rate of compression should be always around 100 to 120 per minute. The depth of compression is at least 1/3 of the anterior-posterior diameter of the chest or 5 to 6 cm deep. Allow the chest to fully recoil after each compression. The chest compression technique for an infant, there are two techniques. The first one is called hand encircling technique. For hand encircling technique, the responders use both of his hands to encircle the infant's chest, and both of the responder thumbs are placed in the center of the chest and lower half of the sternum and provide compression. Alternatively, the other technique is called two-finger compression methods. The index and middle fingers are placed on the center of the infant chest and at the lower half of the child's sternum. The fingers of the responder must always be straight and provide downward compressions to the infant. We look at the first technique, which is two-finger technique, the lone rescuer chest compression for an infant. The responder, one hand of the responder is to hold and stabilize the child's head. The other hand is to use for compression. One can use the middle or ring finger, or my personal preference is to use the index and the middle finger to provide compression. During the compression, both fingers ideally should be straightened at all times and provide downward compression force to the infant. Give 15 compression and 2 rescue breaths for 5 cycles. Minimize interruptions while performing the chest compression. Assess the victim after 5 cycles or 1 minute. Next method is called hand encircling technique. This technique is used when there are two rescuers to provide CPR for that infant. The first rescuer will be positioned above the patient's or the infant's head, and the first rescuer will stabilize the patient's head using both of his hands. The other rescuer, who is the chest compressor, will position himself below the infant's feet, and both of his hands will encircle the child's chest. Spread his fingers around the thorax, make sure he has a good grip. Then both of the rescuer thumbs will place together over the lower half of the sternum. Then it provides Compression falls to the sternum with both of his thumbs. The compression depth ideally should be at least 1/3 of the anterior-posterior diameter of the chest or 4 cm deep. Give 15 compression followed by 2 rescue breaths for 5 cycles. Assess the victims after 5 cycles or 1 minute. D. Defibrillation. Next, we look at the AED or automated external defibrillator that are used in children and infants. The standard adult AED pads are suitable for the use of children aged 8 years old and above. Because the pads, the standard AED pads are usually too big for a child aged 1 to 8 years old. They need a special smaller pediatric pads. However, in a scenario whereby the special pediatric pads are not available, the standard adult pads can be applied to a child aged 1 to 8 years old with the position of the pads placed on the anterior posterior position. For an infant, a manual defibrillator is preferred. After you successfully resuscitated the child and the child shown sign of life by having either spontaneous breathing, any spontaneous movement, or presence of palpable pulse, which means that you have successfully resuscitated the child. Put the child in a recovery position while waiting for the ambulance to bring the child to hospital. In a recovery position, you can put the child either in a left lateral or right lateral. Should you decide to put the child in a left lateral position, extend the child's left arm, then gently roll over the child to the left side. Put the child's right arm across his body with the child's left hand just underneath his head, and gently extend the child's head to open up the airway. And after that, you would like to flex the child's left hip and left knee as illustrated in the diagram. This is to keep the child stable in the left lateral position. For pediatric foreign body airway obstruction algorithm is just like an adult. Number one, you want to assess the severity of the choking. If you decided that the choking is a severe airway obstruction, evidenced by ineffective cough from the child unable, a weak cough by the child is having severe respiratory distress, the child can barely speak, then you will determine the child conscious level. If the child is unconscious, immediately start CPR for the child. If the child is still conscious, you proceed to give the child 5 back blows followed by 5 abdominal thrusts. Repeat the maneuvers until the child has successfully coughed out the foreign body. Should you decide that the child is only having a mild airway obstruction, evidenced by effective cough, can still speak in words or sentences, is in mild respiratory distress, encourage the child to cough. You stand beside the child, continue to check the child for any sign of deterioration. At the same time, encourage the child to cough out the foreign body. For infant choking, is almost similar as the adult. However, for infant, because infant is a child less than 1 year old, their abdominal muscle is not well developed. That's why we don't do abdominal thrust in an infant. It could injure the abdominal organ such as liver or spleen. In an infant, we give chest thrust or chest compression in an infant who is choking. Should you perform CPR in an unconscious choking child, every time the airway is open, the rescuer should look if any object is seen and that can be removed. Never perform blind sweep to remove the foreign object, as you could risk pushing the object further down into the infant's or pediatric's throat. For case of mild airway obstruction, do not interfere with the child coughing. Stand beside the child. Encourage the child to keep coughing until the foreign body is successfully coughed out. Observe the child for any progression to severe obstruction. Severe airway obstructions in a child or an infant is evidenced by the child or infant having serious breathing difficulties, ineffective cough or weak cough, the child's skin or lips become dusky or bluish, the infant having a weak cry. If the child or the infant is still conscious, provide 5 back blows followed by 5 chest thrusts in an infant or 5 abdominal thrusts in a child. Repeat the maneuver until the object is dislodged from the child or infant's mouth or the victim becomes unconscious. To perform back blows and chest thrusts can be illustrated by the pictures below. To perform back blows, hold the infant in a prone position on one hand, while the other hand provide 5 back blows to the infant. After you perform 5 back blows, turn the infant into a supine position and place the infant on a flat surface. One hand hold onto the infant's head to stabilize him, while the other hand, 2 fingers of the other hands, provide 5 times chest thrust. At any moment, if you can see the foreign body is inside the infant's mouth, gently sweep up the foreign bodies. Alternate back blows and chest thrusts until the foreign body is expelled out from the infant's mouth. For a choking child, you can gently bend the child forward and perform 5 back blows from behind, followed by abdominal thrust, which is similar maneuver that you perform in a choking adult. For severe airway obstruction in a child or an infant who become unconscious, one needs to perform CPR for the child or the infant. Call for help if second rescuer is available. Ask the second rescuer to immediately call 999 or activate emergency medical service. Support the victim on the ground. Open up the airway. If the object or foreign body is seen inside the patient's mouth, use a single finger to gently sweep up the foreign body. Then try to ventilate the child by giving 5 rescue breaths. If there is obstruction and you're unable to ventilate the child, reposition the child's head and attempt to ventilate the child again. After giving 5 rescue breaths, immediately start performing CPR by doing chest compression to ventilation in a 15:2 ratio. For a single rescuer, perform CPR for duration of 1 minute. After 1 minute, if the airway obstruction is still present or the foreign body is still not clear, call 999 and activate emergency medical service. This table summarizes the basic life support algorithm that is provided for infants, children, and adults. For an adult, we take age 8 years old or more, or some take as 12 years old and above to take as an adult. For a child is 1 year old to 8 years old. For infant is below 1 year of age. We start with activating emergency medical service for a lone rescuer scenario. For an adult, immediately activate the emergency medical services if the victim is found unresponsive. In an asphyxial arrest situation, provide initial CPR for 2 minutes. For child and infant, one should, if the child and infant is unconscious, immediately provide 5 initial rescue breaths followed by 1 minute of CPR. After 1 minute of CPR, then only activate the emergency medical service. For a sudden and weakness child collapse, activate the emergency medical service immediately. Next, airway and breathing. Perform head tilt and chin lift to open out the airway. Use jaw thrust if the victim is a trauma case. Check quickly for normal breathing. Take no more than 10 seconds. For an adult, if there is no breathing, no spontaneous breathing in an adult, immediately perform chest compression. For a child or an infant, if there is no breathing noticed, immediately provide 5 rescue breaths to the child or infant. Next, circulation. Checking for sign of life or trying to palpate the carotid pulse is not encouraged in the initial assessment for the adult. For child or infant, you can take no more than 10 seconds to look for sign of life. If there is no sign of life, immediately start chest compression. Next, chest compression. Push hard and fast on the center of the chest, which means the lower half of the sternum, at a rate of 100 to 120 per minute. Then allow the chest to fully recoil in between compressions. Minimize interruptions in compressions. Next, compressions to ventilation ratio. In an adult, perform 30 compressions to 2 ventilation. For child or infant, the compressions to ventilation rate is at 15 to 2. Next, compression depth. For an adult, at least 5 to 6 cm deep. For child or infant, at least 1/3 anterior-posterior diameter of the chest. Typically, 4 cm in an infant or 5 cm in a children. Next, rescue breathing without chest compression. At any particular moment during CPR, if there is a presence of pulse or a palpable pulse, one should only focus in giving rescue breath if you deem that the breathing of the victim is still insufficient. To provide rescue breath in an adult, 12 breaths per minute or approximately 1 breath every 5 seconds. A good timing to provide rescue breath in an adult is 1 and 2 and 3 and 4 and breathe. For a child and an infant, the rescue breath is provided in a rate of 12 to 20 breaths per minute, or approximately 1 breath every 3 to 5 seconds. The timing of the ventilation shall be 1 and 2 and breathe, 1 and 2 and breathe, 1 and 2 and breathe. Next, AED defibrillation. In an adult, start CPR and use the AED as soon as it is available. For child and infant, for a child, start CPR. Preferably use child pad once the AED is available. For if in a condition that the AED is available but child pads is not available, one can use an adult pad but place the adult pad in a position of anterior, one chest pad over the anterior while the other chest pad over the posterior position. For an infant, currently there is insufficient evidence to support recommendation for or against the use of AED in an infant. We have reached the end of my presentation. Should you have any question regarding my lecture or presentation, feel free to ask the facilitator. Thank you.